So our next speaker is Dr. Marissa Kellogg. Dr. Kellogg is a neurologist and associate professor at OHSU, specializes in caring for adults with epilepsy and seizures. She currently serves as the director of the VA Portland Epilepsy Center of Excellence. She also serves as a board member for the Epilepsy Foundation Oregon. She didn't put that in her bio, but I'm putting it in there. Her research interests include epilepsy clinical trials, clinical outcomes, genetics, epidemiology, and global neurology. She recently received 2 federal research awards to study the genetic epidemiology of epilepsy using data from one of the world's largest genetic research databases, the Millen Veteran Program Biobank. She has collaborated in clinical care and clinical research and with healthcare providers in Tanzania, Thailand, and Botswana. In her spare time, Dr. Kellogg enjoys cycling, reading, travel, and exploring the Portland playground scene with her family. Please welcome Dr. Kellogg.
Hello, everybody, and thanks for coming in on a Saturday. I know that's a big ask. So I'm going to be talking about who might benefit from genetic testing for epilepsy, and I'm really going to try to keep the medical jargon to a minimum. But if I'm using words that I don't define well enough, please feel free to raise your hand and interrupt me and say, hey, do you mind talking a little bit about that concept a bit more? Or I'm more than happy to take questions in the middle of the talk if they're clarifying questions. So no financial disclosures beyond my employment at OHSU and the Portland VA. And then, of course, as a federal government employee, I'm supposed to tell you that these reflect my personal views and research and not that of the federal or state government. So the learning objectives of this talk, I'm going to broadly review our current understanding of epilepsy genetics, which has advanced rapidly over the past 20 years. We're going to identify who might benefit from genetic testing for epilepsy according to recent scientific evidence-based guidelines. We're going to recognize that we still have a lot to learn about the genetics of epilepsy and that precision medicine has incredible promise, but it's very much in its infancy, and it has not yet delivered on the promise that we do see coming very closely down the line. And then finally, I'm going to discuss the risks and benefits of genetic testing so people can make an informed decision about whether genetic testing is right for you or them. So why am I talking about this topic? I've been an epilepsy provider, just caring for people with seizures and epilepsy for 9 years now, and further neurologic training before that. And I've had even though, again, genetic testing is in its infancy, I've had a lot of patients affected by genetic epilepsies. For example, a 42-year-old veteran and VA employee with drug-resistant epilepsy who died of sudden unexplained death in epilepsy. We've since learned that there are a lot of genetic susceptibilities to SUDEP, sudden unexplained death in epilepsy. And, if he'd gotten genetic testing, what if we had been able to identify his risk ahead of time and intervened, before he tragically died at 42. Also, a 36-year-old with a long history of episodic spells of loss of consciousness and a child with seizures was found to have a pathogenic variant in a single gene called KCNH2. And just to note, these kind of capital letters, that, usually about 4 to 6 letters long, sometimes with a number, those are gene kind of name symbols. And I'm not going to bother kind of spelling out those whole genes, but just for the rest of this talk, you're going to episodically see those pop up, and I'm identifying how we know the gene best. But this gene is associated with seizures and arrhythmias, including long QT syndrome, which can lead to sudden death as well. And this patient, and his child were referred to cardiology for further evaluation and then counseling about their risk and, counseling that could be directed at preventing their risk of death. Also, a previously totally healthy 28-year-old developed bizarre behavior and verbal unresponsiveness. She was admitted to a psychiatry unit for 2 months before she had her first convulsive seizure. They finally connected an EEG, and she was in status epilepticus, meaning, seizures that weren't stopping. She was found to have a pathogenic variant in POLD1. And this is just to illustrate that, genetic testing is not just for kids. There are adults with adult onset epilepsy who also have genetic epilepsies. It does tend to be, more, prevalent in childhood onset seizures, but it still happens in adults. And then my final example is I've also cared for a 49-year-old veteran with drug-resistant epilepsy who was incidentally found to have a variant that made him at increased risk for a cancer syndrome on his genetic test. And so he was able to get a colonoscopy and get an earlier diagnosis than his loved ones who died of colon cancer. So, these are just, some cases to illustrate the potential strengths of genetic testing and that there are genetic causes and susceptibilities in the development of adult onset epilepsy. I do want to alert you, though, that these are all rare variants. So don't think that, these are, exceptional case examples and, less than 1% of the population, less than 0.1% has these conditions. So what is genetic testing? Genetic testing analyzes a person's DNA to identify genes, chromosomes, or proteins in their body. DNA changes, also known as genetic variants, or what we used to just refer to as mutations, but we kind of moved away from that term. These can indicate a genetic condition, disease, or more commonly, and I want to emphasize that it's usually an increased risk for developing a condition or disease. There are very few genes that if somebody has that gene, they're definitely going to get something. So when you have these genes, it increases your risk to a different degree, depending on the gene and the variant. It's not a, 100% you're gonna get this condition. And then just the logistics, these days, a DNA sample can be collected by a routine blood draw, but it also can be a cheek swab. And I guess even some people are just getting saliva kits where they just don't even swab their cheek. They just spit into a saliva collection thing. So how many epilepsy genes are out there? Does anybody think actually, if people could raise their hands, who thinks there are less than 100? Okay, good. Who thinks there are more than 200? More than 500? More than 750? More than 1,000? So there are more than 1,000 epilepsy-associated genes that have now been identified. It's kind of mind-blowing. And as you can see in this graph, we're looking at, from the time the first epilepsy-associated gene was discovered in 1997 through 2023, there's been an exponential rise in discovery of epilepsy-associated genes, particularly, kind of the pivot point is around 2010 when next generation sequencing rolled around. And what that is a technology introduced in the last 20 years that greatly improved the speed and precision of genetic testing. The other reasons that we've discovered these genes is that there's been increased genetic testing of individuals and huge multinational data sharing efforts that have led to better understanding of genetic risk. And I've participated in some of those efforts. And then a huge and important contribution to all this is collaboration with disease advocacy organizations such as the Epilepsy Foundation, who's really pushed the field forward. So these are just some of the organizations that have really pushed the field forward. And you can see a lot of these organizations, such as KCNQ2 or PCDH19, or this cure shank is another gene. Some of them are totally based on the gene condition or gene variants that are associated with that condition. And one, I'm going to give a special shout out to the Rare Epilepsy Network that has down here that kind of brings these organizations together to a certain degree too. So I'm not going to have a lot of genetic kind of, I'm going to talk more about the logistics for you and the considerations for you personally. This is going to kind of be only the only sciencey kind of slide that we're going to have, but I can recommend others if you want to learn more. So the question is, does a certain type of epilepsy, is a certain type of epilepsy caused by damage to a certain gene, such as, this little purple pathogenic variant there, which means a damaging variant. Sometimes it can cause one type of epilepsy, but it's usually more complicated than that. Often a single gene mutation can cause a whole spectrum of different types of epilepsy and associated conditions. And it can be totally asymptomatic, meaning person never has a seizure in their whole life, to presenting with early, childhood onset disabling developmental conditions. So it's a huge spectrum, and we still don't understand, why one person appears to be spared by that gene while another person is profoundly affected. But more and more, we're also recognizing that epilepsy can be what we use the technical term polygenic, meaning that someone's risk of seizures is increased by combinations of genetic variants. So as you can see, there are a lot of different, more subtle and less damaging gene variants that kind of combined increase that person's risk. However, it's really important to know that particularly in adults, genes rarely act in isolation. There are many environmental factors that also influence phenotype, which is a fancy word for any observable characteristics in a person. So, is all genetic epilepsy inherited from a parent? No. Genetic epilepsies are not necessarily inherited from a biological parent. De novo is the term that we use to describe gene mutations that are not inherited. And they can arise either during conception, and we call those germline variants or germline mutations that lead to the genetic change occurring in all cells of the body, or they can occur after conception, what we term somatic, which only leads to changes in certain cells of the body. And we refer to this as mosaicism. And this is just kind of an illustration of how it works. Here you have a fully healthy zygote after conception, and then only a single gene, depending on when that occurs, has a mutation. And depending on what that single cell grows into and where in the body it goes, people can have the genetic findings only in certain parts of the body. And there's been a ton of research in the last 10 years that have shown that it might just be in one part of the brain. And focal cortical dysplasias or certain brain abnormalities, we see lots of evidence of this. And it's a really exciting development because, the more we learn about this, the more we're going to have targeted gene therapies for these patients that hopefully could spare patients, the nasty side effects of all our toxic medications. So who should get genetic testing? About 2 years ago now, almost 2 years ago, some evidence-based practice guidelines were published that strongly recommend genetic testing and counseling for all individuals with unexplained epilepsy at any age. They further recommended, and this was performed by the National Society of Genetic Counselors, but it was endorsed by the American Epilepsy Foundation, which is the kind of official professional organization for all epilepsy specialists and researchers and advocacy organizations throughout the country. This guideline further recommended that genetic tests be selected, ordered, and interpreted by a qualified healthcare provider in the setting of appropriate pre-test and post-test genetic counseling. So why is genetic testing for epilepsy important? First, it can answer the question of why do I have epilepsy? Unfortunately, there's currently not a straightforward answer for at least half of people who develop seizures, and genetic testing can answer this question for an increasing number of people affected. What are my chances of seizure freedom? Certain genes and gene variants are associated with different prognoses over the life course, though there's a lot of heterogeneity. And what's the best treatment for my type of epilepsy? Increasingly, there are precision medicine treatment implications for different types of genetic epilepsies. For example, people with a certain SCN1A gene variant might benefit from sodium channel blocking medications like lamotrigine or oxcarbazepine, while others should avoid these medications. So how can genetic testing inspire the formation of community advocacy groups? Well, somebody gets a genetic test. They find out that they have one of these gene variants. They reach out on social media to their friends, to their network, to the Epilepsy Foundation, to the Rare Epilepsy Network, and they learn that they fall on that spectrum of phenotypes or clinical manifestations that fits well with that gene. Then as more people get together, as more people share information, as more people reach out to pharmaceutical companies or therapeutic companies to advocate on behalf of their family members or themselves, it leads to funding, to research, to pushing the needle forward, to understanding the brain's inner workings, not just for treatments for people with epilepsy, but it's also helped for treatments for people with autism, with bipolar disorder, schizophrenia. Lots of different conditions are touched by epilepsy, and the therapeutics that we've developed in epilepsy have really impacted a lot of different conditions. So what are the risks and benefits of testing? I've already kind of gone through some of the benefits, but I'll highlight some more. Sometimes people can get a sense of relief from the uncertainty of not knowing, why. It can help people make informed decisions about managing their healthcare. It can save the patient and family from further unnecessary diagnostic procedures. It may help in the selection of optimal therapy, but I must caution, we're really not there yet for most of the findings. Please, if you do get testing, do not expect that today those results are going to change your management. They might. I'm not saying they won't, but we're not quite there yet. The results could direct a person towards available monitoring and treatment options, and some test results could also help people make decisions about having kids or how to have kids, whether they want to use assistive reproductive therapies, and then again, connect with others who are similarly affected. But there are many risks and limitations of testing as well. There are emotional, social, and financial consequences of testing. People might get results and feel angry, depressed, anxious, or guilty. It may and very much can affect family relationships because the results can reveal information about family members other than the person who is tested. The extreme cases being if there's consanguinity in the family, people closely related who have children, or if non-parental biological parental connections. So there is unfortunately still the possibility of genetic discrimination in insurance. Technically, there are laws protecting against discrimination for employment purposes or for medical insurance, but for disability insurance or long-term care insurance, there are not those protections. And then results, especially these days, can still be uninformative, incomplete, or misinterpreted. So caution there. So if you choose to get testing, how would it work? You'd come into your doctor, they'd, run some tests, looking at your whole clinical situation. They'd help you decide whether testing is indicated. You'd give your blood sample or cheek swab sample. They'd send it to a lab, usually somewhere else, usually a commercial lab, since most hospitals are not doing their own genetic testing quite yet. They'll generate a report. It usually takes at least a month to get back, sometimes less, but usually on the order of 1 to 2 months. You'll come back in for a visit and discuss the findings. It may lead to, the case being solved, or the case might not be solved. And then, the provider, and hopefully with a genetic counselor, will be able to kind of figure out, help figure out what the next steps might be. People who have a higher likelihood of genetic causes include people with severe childhood onset epilepsies, intellectual disability, autism, congenital brain abnormalities, drug-resistant epilepsy, or a strong family history of at least 1 first-degree or 2 second-degree relatives with epilepsy. And also, again, the chances of having a genetic cause decrease with increasing age. So the younger the age of onset of seizures, the highest risk you are. And so what will the genetic testing results tell us? So basically, there are 3 possibilities. Number 1, the case can be quote unquote solved. We also call this a molecular diagnosis, where causative pathogenic variants are found that totally explain your epilepsy. And that's kind of best case scenario. That is in say kids under the age of 8. That happens about 25% of the time with certain types of tests, and up to 50% of the time with other tests, depending on the test. And I'm not going to go over the different testing options today, but I will give you references if you want to learn more. The second I'm going to skip to number 3 first before I go over number 2, which is the most complicated and frustrating result. So number 3, it might be negative. Your test might be negative, but an uninformative result does not mean that a genetic cause has been excluded. It rather means that the test that was sent that day didn't find anything at this point in time. If you remember that slide that I showed you of the increased recognition of epilepsy genes, we haven't stopped discovering them. We're still discovering them at a rate of like 5 to 10 genes a month. So those genes that we haven't yet discovered are not going to be on that report. There are bigger kind of structural findings that we also won't discover on certain types of tests, where we will discover them on others. So a negative test doesn't mean that you don't have a genetic contributory factor to your seizures. In my 8 years of setting testing, unfortunately, the most common thing that our group at OHSU on the adult side has encountered are these variants of uncertain significance. And what they mean, they're equivocal, basically. At this time, we cannot say whether they're contributory to your increased risk of seizures or not. We just don't have enough information yet. And we hope that in the next 20 years, all of these will be reclassified. That's our hope. And what it's going to take to do that is further research in this field, and more people getting genetic testing, and more of the advocacy organizations banding together and advocating for this to happen too, and companies as well supporting this. So the other thing that you should know about that is definitely an evolving field that's evolved in the last 5 years I've been sending testing, is that depending on the type of genetic test, you may or may not be able to choose to receive information on variants that are not associated with epilepsy, which we refer to as secondary findings. So if you want to get testing just for your epilepsy and you don't want to know your cancer risk or things like that, those are called primary findings. And they can potentially do an epilepsy gene panel with testing just for genes that increase your risk for seizures. Make sure you talk with your doctor and your genetic counselor about your wishes, because unfortunately, given the VA contracting and things, I send a panel to a new company, or fortunately, and they had included secondary findings. So secondary findings are incidental findings unrelated to epilepsy, but may have significant implications for a person's health, such as a cancer susceptibility gene like BRCA, or Lynch syndrome, or cardiac arrhythmia causing genes. So you may want to know these, or you may not. And increasingly, these are also being included in your report. And depending on the type of testing you're going to get, you may or may not have these included. So I already kind of mentioned this. A negative test does not, these are the limitations of genetic testing at this time. A negative test does not exclude the possibility of an underlying genetic disease. Many of the variants of uncertain significance reported will become better understood over time. Several types of genetic variants are not robustly detected by next generation sequencing, which is the most common method used today. So other types of genetic tests are needed. When you do get a report that a gene is present, it's probably there, but it's more difficult to determine the significance of that variant. And then laboratories do their best to accurately label genetic variants as pathogenic, positive or not pathogenic, but classification may be incorrect, and it may actually waver back and forth from benign to pathogenic to variant of uncertain significance as we gather more patient data and more people put their heads together over the findings. So emerging evidence definitely leads to reclassification in a lot of cases. And then the original report would then have been a false positive or a false negative. This is a good online reference. If you really want to jump into the weeds of what your report shows and how to interpret it. And so you might be wondering at this point if you haven't had genetic testing yet. So if it's potentially so helpful, why isn't everyone with epilepsy getting it already? Well, we've talked about some of the, the risks of testing. So those are big reasons. But also there is limited access to genetic expertise and counselors due to the numbers and insurance and cost considerations. And then how do we interpret and communicate these equivocal or complex results? That can be challenging and intimidating to neurologists and other providers. And what if the results have non-neurologic implications? Neurologists such as myself feel uncomfortable counseling somebody about, their cancer risk. But I mean, that might have a even bigger impact on their health. So maybe we should be doing it anyway. It's time intensive, it's rapidly evolving, so it's hard to stay current in this field with over 1,000 genes. How on earth can we know about all of them? And at some point, theoretically, all of us are going to get whole genome sequencing where they're going to be able to read all of our DNA. That's too expensive right now, but in 100 years, it's probably going to be the norm. While we're, approaching that time, what do we do in the interim and what kind of tests do we send, knowing their limitations? So just about to wrap up, but if you want to pursue or consider getting genetic testing for epilepsy, what should you do? Ask your neurologist about genetic testing, or at least to talk about it. Most likely, they will refer you to a genetic counselor or medical geneticist, which is a physician specially trained in genetic medicine, for consideration of testing and choosing and ordering the appropriate test. Some neurologists or pediatricians may feel comfortable sending the testing themselves, but not yet the majority. And then these are some great references where you can read more about testing options and guidance and kind of the exciting information that's been evolving in the field. I particularly would encourage these Cure Epilepsy webinars that have all been posted online for free in the last year because they talk about the most current results from some of the world's experts in I think pretty accessible language. And I think they very much complement what I've been talking about today. So that is it. Thank you for listening, and please let me know if you have any questions.